as you probably know, type 2 diabetes is an epidemic condition, but there is some concern that among our providers that we are accepting probably less than the standard of care for the management of type 2 diabetes. And what do I mean by that? Well, when a patient comes into your office, do you examine them and check their feet and make sure that they've had all their diabetes healthcare maintenance completed? And once you do that, what target of diabetes control are you aiming for, and is it appropriate for their age and their comorbidities? The American Diabetes Association has changed their thinking a bit on the goals of care. And certainly if you're younger with type 2 diabetes, we want a more aggressive management style. If you're an older adult with multiple other medical problems, then the goal hemoglobin A1C, rather than being 7, maybe 8%. So what we're going to talk about today are some of the different ways one can personalize the medical care of a patient with type 2 diabetes, but also prevent yourselves as a health provider from getting into this state of clinical inertia. Diet and exercise always remains the mainstay for management of metabolic syndrome and diabetes, but if diet and exercise isn't working, you can't keep saying, please change your diet, please exercise more, and allow patients to have continued elevations in their blood glucoses. When we see that happening, we worry that we are allowing our patients to develop beta cell exhaustion, if you will, so that they may not be able to make enough insulin to keep their blood glucoses under control, and you may actually accelerate the natural history of type 2 diabetes, which is that many patients after 10 to 20 years of type 2 diabetes may end up being insulin requiring. So every patient that comes in with diabetes is not the same. They come with a different family history. They come with a different metabolic profile that needs to actually be determined during the visit. Do they have hypertension? Do they have high cholesterol? Do they have heart disease already? They come with different social situation. One of the things you'll probably hear us talk a lot about today is that we have many new medicines for the management of type 2 diabetes. We have new classes of oral agents, we have new injectables that are not insulin, we have different formulations of insulin. But if you have a patient who is on a fixed income or who does not have health insurance, then it is not personalized care to prescribe for them the most expensive medications out there. And in fact, sometimes we see this happening when a patient such as this may come into the hospital, they get prescribed some of the newer medicines, people forget to check if they can afford them, they go home, they can't afford them, they stop taking them. So there are many things that you have to think about when you're thinking about personalized care for a patient with diabetes. And I think one other thing you need to include is their understanding of their disease. And so we cannot forget that part of the team that has to take care of the diabetes includes the patient. So that's when you personalize their healthcare literacy. Can they even read? You know, we have a lot of information given to patients that's remarkably complicated, and can they understand what we're saying? Do they have math literacy? If you decide that you want to take a patient with diabetes and tell them to adjust their own insulin, and they don't know how to add or subtract, then you've actually put them in harm's way. So I think there's lots and lots of things that we need to assess in a remarkably short period of time in patients' personalized care for diabetes. And it will be the opinion of our panel, I'm sure, that it takes a team to make that happen.